Welcome to Hillary Topper on Air, the podcast where we explore topics that matter most to athletes, professionals, and everyday individuals. Today, we're diving into a subject that hits close to home for many of us, ACL and meniscus tears. As athletes, especially runners and triathletes, we often push ourselves to the limit. But how far is too far? Take, for example, Olympic skier Lindsey Vonn, who famously competed with a torn ACL. While her determination was inspiring, it raises the question, was it the smartest decision? She ultimately fell and sustained further injury, breaking her leg. It makes you wonder how much you can push through an injury like this without causing more damage, and when you should stop. To help us navigate these questions and more, I'm thrilled to welcome Dr. Sabrina Strickland, a renowned orthopedic surgeon specializing in sports medicine at the Hospital for Special Surgery. Dr. Strickland has extensive experience treating ACL and meniscus injuries, and she's here to share her insights on prevention, treatment, and recovery. Whether you're an elite athlete or weekend warrior, this episode is packed with valuable information you won't want to miss. So, Dr. Strickland, welcome to the show. Can you give us a little bit about your background and your practice?
Sure. So I'm an orthopedic surgeon. My specialty is sports medicine, which I think is like a little bit of a, a misnomer just because I take care of lots of people who don't consider themselves somebody who plays sports. But I mean, lots of patients want to keep going to the gym, and lots of people want to keep walking their 5 or 10,000 steps around New York City. And so I take care of that whole spectrum of patients. I take care of 12-year-old lacrosse players, and I take care of 65-year-old skiers. And so it's a huge spectrum, but predominantly I do knee surgery. I started kind of 50-50 knee and shoulder. I do predominantly knee surgery at this point. I certainly take care of pretty common shoulder problems. But I did a orthopedic residency for 5 years and then a year specializing in sports medicine. All my training was here at the Hospital for Special Surgery.
Cool. Thank you. So, can you talk to us a little bit about ACL and meniscus tears and what's the difference between them?
So, first of all, the ACL is a ligament, and ligaments are bands that connect one bone to another. That's how um, when you sprain your ankle, you're tearing a ligament, and when you tear your ACL, you're tearing a ligament. And the ACL is a really important structure for anything that involves any kind of pivoting or twisting. And so lots of people can get away with and live with their ACL tear as long as they're committed to just going in a straight line. So walking, biking, swimming, most people are fine without an ACL. But most people I see tore their ACL doing a sport that involves twisting. And so most people want to get back to that. So the vast majority of patients I see with an ACL tear end up having surgery. The meniscus is a completely different structure. The meniscus is a type of cartilage, and it's a fibrocartilage, so it's a cushion. And because the thigh bone is round and the shin bone is flat, you need a cushion or a shock distributor so that you don't prematurely wear out the knee joint, and specifically the cartilage that covers the bone. So the meniscus, it's a cushion. The problem with that cushion is, and if you saw a meniscus, if I showed you a meniscus, it looks like a piece of rubber. And the problem with the meniscus is it only has a blood supply in the peripheral 25 or 30% of it. So it's almost like your cuticle. Like if you get a hangnail, it's not going to heal. You can't sew it back. It's kind of dead skin. But if you cut yourself closer to your finger, it can bleed, it can heal, it can get better. And the meniscus is similar.
So, are there specific sports or activities that put people at higher risk for either one of them? I mean, you kind of
So
alluded to the ACL. I was thinking maybe skiing.
So right now we're in ACL season because there's so many skiers and so many people tear their ACL skiing. But the most dangerous sports that we see for ACLs are soccer,
Mhm.
basketball, lacrosse, and just pivoting sports in general. And So that the people who play those sports tend to be younger, and certainly we see skiers, and everybody's talking about ACLs after um, Lindsey Vonn's accident, but obviously many skiers on the World Cup tour, the Olympics, have gone through ACL reconstruction after an ACL tear. So sports for ACL are twisting sports, and it's a real injury. The meniscus is different. So young people, so patients in their teens or 20s who tear their meniscus, usually have a story. Um, they twisted their knee in some way, so it can be a similar kind of injury to an ACL. But most meniscal tears I see are patients over 30, often over 40, where they really didn't do anything. They can't even think of what happened, or maybe they just got something out from under their kitchen sink. They may or may not feel a pop in their knee, but often they'll feel swelling and their knee will feel tight, and they may have catching or locking. So it's a very different sensation and than having an ACL tear.
Hmm, that's
ACL,
interesting.
the minute it happened, you tore your ACL, or something bad happened.
So let me ask you the $50,000 question, right? Was it really smart of Lindsey Vonn to be in the Olympics after having a torn ACL?
Believe it or not, our hospital says we can't comment on that accident, which I'm not her doctor. I don't know.
Okay. Okay.
If it was you and your ACL, would I tell you to ski at 80, 90 miles an hour? No, I would say I would worry about that. But
Yeah.
I obviously I don't know
Yeah.
you specifically.
Yeah. Okay. So how can you tell if someone's torn their ACL or their meniscus, and what are the key symptoms? Is it the same symptoms?
No, it's pretty different. So first of all, the story is different. If somebody comes in with an ACL injury that was recent, they typically have a lot of swelling in their knee. They often have some trouble moving their knee. They may even have trouble putting weight on their knee, and they usually have a story of an actual injury. And so what I do when I first see them is I feel their knee, and I can feel that their knee moves more than it normally should, because that ACL is a ligament that keeps the shin bone from coming too far forward. So when I feel it, I can feel the difference. So a meniscus is different, where patient may or may not have a history of trauma. Usually it doesn't swell immediately. Often it's the next day they'll start feeling tight. Some people just have pain on the inside or the outside of their knee. It's more focal. It's just kind of, they can point to one side or the other. And then some people will say, um, when I get up and start walking, it takes me a few steps till I sort of feel like I don't have to limp anymore. But then they're like, once I start, I feel okay. So that's a very common story for the meniscus. Other people will say, it feels like it occasionally gets stuck, and then I have this sharp pain, and then it goes away. And like, why would they have that sensation? Because literally it can be like a little piece of the tissue is moving in and out. And if it's moved back kind of where it belongs, it may not hurt very much. And then it moves out of place, it can hurt a whole lot.
Wow.
But
So,
how do I tell? I'm sorry, just how do I tell? I push on the side of their knee. I look for swelling, but it's not as definitive as feeling an ACL, where you just feel like the knee is loose and there's no ligament there. So it's
gotcha.
different.
It's interesting. So, what are some of the treatment options for these types of injuries?
So starting with the ACL, just most people elect to have surgery, and we basically have two different ways we can fix an ACL. Number one, we can fix it, meaning we can put some stitches in the torn ACL and tack it back to the bone. And that's what they did 35, 30, 40 years ago, before we got good at arthroscopy. They'd open it up, they'd put a bunch of sutures in it, they'd put you in a cast, your knee would get super stiff, and sometimes it would work. But a lot of patients had a lot of stiffness, and it didn't work that well. So um, more than 30 years ago, we started doing a reconstruction, where we would take something typically from your body, your patellar tendon, your hamstring tendon, your quad tendon, and then we would feed it through drill holes in the bone, essentially where your ACL was, and we would basically be putting a tendon where a ligament was. And the human body is smart. It kind of sees this collagen in the right place, and it would turn it into a ligament. Like, you would grow into it. And that ligamentization process really takes a while, like 6, 9 months, and that's why we typically don't let patients go back to cutting sports for that period of time, to
Wow.
protect it during the healing. Um, the repair has become a little bit more common lately, because there's something called the bear, bear is a bovine, meaning it's from a cow, collagen sponge. And so you do that same kind of repair, but you add this sponge, and that's been shown to work pretty well as far as getting the ACL to heal. There's pros and
Interesting.
cons to both.
So, how do you determine whether surgery is necessary versus physical therapy?
So for the ACL, it really is what kind of sports you want to get back to, and or if it's feeling unstable with day-to-day life. So I had a patient years ago who was on the subway. It stopped suddenly. She lost her balance. She tore her ACL. So she wasn't playing sports, but she was only 30. And so she came in. She said, "You know what? I don't think I need surgery. I'm not going to play tennis. I'm not going to go skiing. I just, I just want to like walk and ride my bike." But just walking around New York City, she said she'd like hear a noise and kind of twist her body a little bit, and she'd feel her knee kind of give way. So she ended up having surgery, even though I wouldn't have considered her a high risk and somebody who would definitely need surgery for it. The meniscus is totally different. So if the meniscus is torn in a way that we can sew it back, we always want to do that because we want to keep that cushion. It was there for a reason. You want to protect it. But if it's just a little flap, and it's in an area which doesn't have a good blood supply, we can leave it alone. We can ignore it as long as you're feeling okay. So it's really based on, we typically get an MRI, look at the kind of tear it is, and then depending on how you're feeling, we decide if we're going to go in and do a tiny little surgery and snip out the unstable part, or we're going to just leave it alone and hope your body forgets about it.
Now, a lot of people try to push through activity even though they have a meniscus injury. Is that a smart thing to do, or is it better just to rest and do the rice thing?
Well, short term, it's better to rest and do the right thing because you want, especially if the knee is swollen, because as soon as your knee swells, it shuts down your quad and you lose range of motion. So you want to get that inflammation down, but you don't want to get that inflammation down at the expense of losing all your strength. So there's always things you can do, like you can do straight leg raises, you can do little wall squats, you can often get on an exercise bike, so you can do something, but you certainly don't want to go out for a run if your knee is hot and swollen.
Yeah. A lot of people say to me, that they need, I mean, this is kind of off subject a little bit. They need their orthopedic surgeon tells them that they need a knee replacement, but they're going to do physical therapy, they're going to do strength training, they're going to do everything they can to kind of keep that in the back burner. Um, excuse me. Is that a smart thing to do? Or,
Well,
I mean, when is it time to get a knee replacement?
so basically, for something like once you start talking about replacement, where you're going to actually shave off the ends of the bone and put in metal and plastic, that that you want to push that off as long as possible if other things um, make you feel better. So if you can do physical therapy, if you can have injections, if you can wear a brace just for certain sports and feel pretty good, then I certainly wouldn't have a knee replacement, because if you look at large studies of joint replacements, satisfaction rates are somewhere around 80 or 85%, meaning most people are happy, but there's a good percentage that are not happy because they don't have the same function that they were hoping to have.
Yeah, totally. Thank you for that. All right, well, let's get back to ACL and meniscus. So, what does the recovery process look for ACL and meniscus injuries?
So they're quite different. So if for an ACL, because something has to heal and you have to turn that tendon into a ligament, or if you do a repair, you have to allow that tissue to mature. Um, you're starting pretty quickly doing some basic exercises like straight leg raise, and you start bending your knee and you start getting on an exercise bike, and the first 6 weeks are getting over the inflammation and lots of time with the ice machine. But then once you get past that, I tell patients it's the boring phase where you really are just getting stronger for months and months. Most people are back to running between 3 and 4 months.
Wow.
But going back to a sport like tennis or basketball, that's typically at 9 months, and partly it's at 9 months because we want to reduce the risk of re-injury. And the studies say that if you wait 9 months, your risk of re-injury goes down substantially than if you only can wait 6 months. Um, so that's the ACL. But the meniscus is different because if all you do is snip out a little piece of meniscus, it's a tiny surgery and nothing really has to heal. So when you do a meniscectomy, you can get back to your activities much more quickly as long as your knee is quiet. So what do I mean by quiet? That you have your full range of motion, that there's no more swelling, um, that you have your strength back. And so I would say most patients, especially patients who don't have any arthritis, feel pretty good by 4 to 6 weeks, like are doing most things by 4 to 6 weeks.
So let me ask you, are there specific exercises or training techniques that could prevent these exercises?
You mean to prevent these injuries? Yeah,
Yeah.
that I wish. I mean, there's been an enormous amount of research looking at exercises for ACL prevention. So, because we see such high rates of ACL tears, especially in female soccer players, female basketball players, even female skiers, there have been all sorts of programs to try to train girls and women in ways to reduce their risk of re-injury. So, for example, if you look at how a girl jumps and lands playing basketball versus a boy, and this isn't, this is gross generalizations, but it's different. Girls tend to land with a much more stiff-legged um, landing, which puts their knees at higher risk. So doing programs that actually train them to jump and land differently
Mm.
can be helpful. Girls tend to have weaker hips and the angle of our hips, so doing more hip strengthening. And so, like FIFA has a program, the FIFA 11, to do these specific exercises, which are good for everybody. It's not like just girls should do them, but to try to reduce the risk of injury. And there have been studies saying that they can be successful at least reducing the risk if they do all these programs. But even at the highest level, we see ACL tear. So it's not like you can completely reduce or eliminate your risk of ACL tear. The meniscus, the only thing you can really do to protect your meniscus is not tear your ACL. And that's where like these two topics kind of overlap, because if you have an absent or a deficient ACL, it puts your meniscus at a much higher risk of tearing. So let's say you were like the patient I talked about earlier who tore their ACL in the subway, and the only risk going forward is that the knee will either buckle or be unstable, which is ultimately why she had surgery. But every once in a while, if it does buckle or give way, you can then tear your meniscus, and then now you have two problems. You went from one problem, the ACL, to now you have an ACL in the meniscus, because the meniscus, even though it's a shock absorber, also is a secondary stabilizer for the knee. So the ACL is much more important as far as stabilizing, but the meniscus is secondary. So they
Mm.
do go together and they do overlap.
That's so interesting. Now, for triathletes and runners who are prone to pushing their limits, because that's what we do, what advice would you give them to balance ambition with safety?
So, I mean, one thing that people, one sort of misconception about running is bad for your knees. So that's not true. Running is not bad for your knees. That being said, if you don't have a perfect knee, it sometimes can be hard to run, meaning running does have a lot of joint reactive force. So if you don't have a perfect knee, not everybody can handle running. Not just psychologically, it's like the knee will swell and it'll get angry. So I think really one really important thing for runners is to cross train. Like it's that's why I like triathletes, because they want to get better at swimming, they want to get better at cycling. So if you mix it up, I think you're much more likely to be successful. Secondly, we need different types of stress on our joints. So doing just cardio, in my opinion, is not enough. You want to do cardio and a strengthening program. And whether it's you're going to a gym and you're using a Cybex circuit, or if you're going to Pilates, or you're doing free weights at home, it doesn't matter. You just need a program that stresses your bones and joints in different ways than just running. So I mean, I think those are my two bits of advice.
Yeah, is there any way that an athlete can recognize when it's time to stop or seek medical attention? I mean, I know it sounds kind of simple, but I don't know that people know when to stop.
Well, certainly, if the whole no pain no gain, I think like that doesn't make any sense. Like if you're sore and your muscles are sore because you maybe ramped up more quickly, that's one thing, but you should feel fine the next day. if it should be that your muscles are sore, not your actual joint is sore. So that would be one reason to seek medical attention if the joint is actually sore, especially if it's sore the next day. So if you're sore the same day, okay, I'll maybe give you a pass on that one. But the next day, if you're sore the next day, and if that happens once, no big deal. But if that is a continued pattern where you're paying for it the next day, that's probably a sign that maybe you should at least find out what's going on. Um, the the mistake, I mean, I see a lot of runners as we get towards the marathon, or get even towards the half marathon, is like, if it's getting worse and worse, like, you should be getting better and better. I mean, so that's an indication that something's not going right. It could be a stress fracture. I mean, there's lots of different reasons that your pain is getting worse as you're getting in better shape. It shouldn't be happening like that.
Yeah, totally. And are there any advancements in sports medicine or technology that are changing the way we treat or prevent these injuries?
Yes and no. So I get 5 billion questions about stem cells, and we've been talking about stem cells for more than 10 years. Um, right now, the only stem cells on the market in the United States, or the only stem cells we can use in the United States, are stem cells we take from your own body. So we can take bone marrow from your pelvis, or we can take fat cells, like mini liposuction. But we haven't shown in a study that that's any better than just taking your own blood, spinning it down, and doing PRP. So most of us have said, you know what, for right now, in 2026, that's probably the best biologic.
Mm,
Now, is doing PRP, like, do you do it prophylactically? Do you come in as a runner and say, I just want PRP, my knee doesn't hurt? No, because we we've shown, there have been some studies showing that it can slow down the rate of arthritis, but there's nothing to say it prevents it or reverses it. There's a lot of really interesting research. It's at the basic science level, meaning in a lab, potential, some animal studies, some just test tube studies, but basically looking at ways to stop or slow down the arthritis cascade, because we know some individuals, their families are just prone to arthritis. We know if you tear your ACL, for example, you have a very high rate of or risk of getting arthritis. We know if you tear your meniscus, you're at a high risk for getting arthritis. So there are drugs in development that ideally we want to treat you with before you get the arthritis. And so all of that is very exciting. And then as far as stem cells, people always say, oh, well, can I just fly to Panama or London? I'm like, you can, but they actually don't have better options than we have right now. So
mm,
the option we're most excited about at this moment, we're starting a clinical trial this year. It's umbilical stem cells. It's a Korean company, so they've been doing it in Korea. So I say, if I was going to fly anywhere, I'd fly to Korea right now, because you can get it without being part of a trial. But basically, they take somebody else's umbilical stem cells, they grow them, and for this study, we're going to do a little surgery and basically implant these umbilical stem cells that are mixed with essentially a hydrogel to hold it in place. But that's just for isolated cartilage defects. That's not for just putting in your knee if you have a touch of arthritis. But
mm,
that is another application, and we'll see. Like, it'll be years before we have this
mhm.
where it's not
Yeah.
on a trial basis. But there's a lot of really exciting research. It's not, none of these things are going to be available in the next couple of years.
Well, thank you so much. This has been so interesting. And I would like to ask you how people can get in touch with you to learn more about your practice and, how to make an appointment with your office.
So, two ways. You can just go to sabrinastrickland.com, which is my website, and there's some button that clicks through to our central appointment scheduling. And ultimately, my goal is to just get patients back to their active lifestyle, whatever that is. So I think that's the best way to just. I also um, try to post anything that I see that's interesting on Instagram. So you can find me on Instagram as well.
Yeah, you have a lot of really great information on Instagram too. And your Instagram handle is
That's a good
Dr.
question.
Sabrina Strickland, I think.
Like, you'd think I'd know, but um, I'm gonna have to tell you. Yeah, Dr. Sabrina Strickland, you're right.
Okay, awesome, awesome. Well, thank you again. Have a great day.
You're very welcome.
This show was produced by Hillary Topper and sponsored by
the Russo Law Group, Long Island's signature elder law, estate planning, and special needs law firm. For more information, visit vjrussolaw.com. And PlayTry, your multi-sport specialist for all your triathlon needs. They have so many opportunities, including franchising. If you love the sport of triathlon, check out playtry.com and learn more about opportunities, or if you want to shop there, check them out. They've got great prices and they've got amazing customer service.